Thailand is a nation where ancient traditions and modern innovation exist side by side. Known around the world for its rich cultural heritage, renowned hospitality, and exceptional healthcare, Thailand has long demonstrated that excellence doesn't require being the largest or the wealthiest. It requires vision. Over the past decade, that same vision has extended into genomic medicine. And through national investment, scientific leadership, and an unwavering commitment for improving patient care, Thailand has quietly become one of the world's most compelling examples of how precision medicine can move beyond scientific discovery and into everyday healthcare. I came back to Bangkok to better understand why. Last year, while leading Oxford Nanopore's population health and precision medicine initiatives, I had the privilege of working alongside my dear colleague, pediatric rare disease expert, Dr. Nabia Sakadina, to convene the INSPIRE Consortium here in Bangkok. And together, we brought together leaders from Thailand, Taiwan, Singapore, Malaysia, Indonesia, China, New Zealand, and beyond to explore one shared challenge. How do we bring the promise of genomic medicine to more patients with rare disease? The meeting was inspiring. The conversations were extraordinary, and the commitment was unmistakable. But as I left Bangkok, one question stayed with me. What does it really take to move precision medicine beyond scientific discovery and into everyday healthcare? To answer that question, I've returned to Bangkok to spend time with one of Asia's most respected physician scientists, Professor Vorasuk Shotelersuk. When I visited Professor Vorasuk in his laboratory, I wanted to begin with one simple question. After 4 decades caring for children with rare disease, I wanted to understand what continues to inspire him about caring for patients in the era of precision medicine.
I have been seeing patients. I'm a pediatric geneticist for all my life. So I'm looking for technology to help my patients. It's not looking for application for the technology. So I see patients for decades, more than 4 decades. We see patients with various manifestations, rare diseases, undiagnosed diseases, which are 2 different categories. And it's impossible for any human being to be able to have experience for all the diseases, because we don't live that long enough to see all the diseases. So we need some kind of help, either for consult as a network of experts all around the world, or technologies. And it's like a dream comes true to have a technology that can give us molecular diagnosis, that can help us help our patients. Without our knowledge of what disease our patient has, we, in the past few years, we have diagnosed some diseases that our group has never heard of before. Several diseases in a month. So that's something we are really excited.
You know, when we were together during that workshop for the INSPIRE Consortium, one of the things that struck me was just how diverse the countries represented were. I'm curious, in that particular event, in bringing together thought leaders across the ASEAN region, did you have the same impression?
NGS is not cheap, but any country, I believe, there are enough resources. We just have to ask and deliver and show them that we are committed. We will do even more than we promised in our proposal.
I think what was so poignant to me when we brought everyone together for, admittedly, you know, a one-day workshop, and then we go away and then we go back to our day jobs, but every individual representing that country, if you will, in the ASEAN region came to the table with a different set of challenges and how they can learn from each other. And I'd love to hear your thoughts on where you see that going, where you see the successes and what are still the unmet needs in that area.
That's a very good point. We are in the area of rare diseases, which our community cannot, each member cannot survive alone. That's the thing that draw people with this mindset into rare disease. We are not, well, sometimes it's friendly competition, but most of the time it's collaborative, because it's a nature that we cannot survive by our own. And this is not the nature of every field. Some field, they have a very fierce competition and they can survive. Winners takes all, but not in rare disease. We have 1 or 2 patients, and we are going to learn more if we collaborate. Maybe a group in Europe, in Africa, have 2 or 3 more families, and together we are going to be able to help our patients more. So first, it's a nature of people in this field with a mindset to collaborate. Then, not just the mindset of the people, databases. If we silo, if we just ask for resource and sequence and have our own database and we don't share with others, it's not going to go anywhere. It's go, but very slowly. But if we share, and now we have a model, federation model, we can keep our data, but our algorithm, our aggregated data, we share, and we grow in even faster. So the way I would think we need a national, regional collaboration, not institutional or research group based. And to do this, maybe at the national level, for some ASEAN countries, policymakers, sometimes they listen to experts from outside of their countries more than experts in their own countries. So it's good to ask for opinions and suggestions, advice from other countries. For example, Genomics Thailand, we are very fortunate that in 2016, Dr. Francis Collins visited us, the previous NIH director. At that time, it's a start point of our national project. Then we spent 4 years in the planning and start Genomics Thailand in 2020. And the most important thing is we now have a workforce and infrastructure for a national project. So we can apply it for clinical use and doing some other things. So I guess this is a model, an example that maybe other countries can adapt for their own context. Basically, you need 3 things. You need experts, academic experts, but that's not enough. Then you need the community, the society to support you, and then the policymakers. At least three parties, 3 stakeholders have to have the same vision, and you need something to drive it, maybe an external expert to drive these three wheels and then go to the one vision, one ultimate goal.
I want to pivot and really focus on your experience as a physician. For families living with rare disease every month and sometimes every day, without a diagnosis really matters. Can you share your experience and what changes when a child finally receives a diagnosis?
Treatable is one thing, it's obvious. If a molecular diagnosis can lead to a specific treatment, that's obvious, anyone can understand, oh, it's beneficial. But it's not there. I mean, the specific treatment is not there every time, and actually it's probably not even half of all the rare diseases. But the other benefits, sometimes it's not less or even more important than specific treatment. They give the parents relief of their unknown. Sometimes they blame themselves that maybe it's because of something the mother did or took during the pregnancy, and it's really make them feel guilty all their life, depression and this and that. But once they know what really happened, it's like open up a new chapter, a new life for them, for the whole family. It gives them opportunity to go on with their life. They know what's the prognosis of the child. In analogy, let's say a child with a very severe symptoms from abnormal chromosome, which is a technology in 1960s. If we don't have the chromosome, the karyotype, the parents, the doctor's team would fight to the last minute, put everything on the child as long as possible. So that's also an opportunity cost for other children that may have a better prognosis, and those patients cannot get into the ICU. But this child, if we can provide a definite diagnosis that what is what is the cost, then the parents, the doctor teams understand, and they are not that difficult to accept natural death. You will be surprised that, okay, now I understand. They move from uncertain, bargaining, anger to accept natural death very rapidly. They even the child die. They die with dignity, with understanding. So this is not easy to appreciate if you are not in that situation. And for health technology assessment, the one who calculate the economic benefits, they have no idea how to translate this into numbers, into money. It's very challenging. But for us, for me that see patients and families going along this diagnostic odyssey, it's really beneficial to them. And also we can give a more precise genetic counselors for other family members. They can go on and have better opportunity to have a healthy child. I have, let's say, previously a family with Pompeii, maybe 20 years ago. The parents accept natural death after we diagnosed their child with this devastating disease, and the child died on the mother's shoulder at home. He doesn't have to die in ICU. And they go on, we do prenatal diagnosis. They have a happy family now.
You've spent most of your career helping to shorten what we call the diagnostic odyssey. And similarly, you've been very involved and a leader in the area of applying genomic medicine to shorten that diagnostic odyssey, even over the last 10 years. Can you say a few words about that?
Oh, yeah, well, I get back from my training in the US in 1999. At that time, I was the only clinical geneticist for this big hospital. I asked, well, at that time, I didn't even have an office. I see patients all the time, and then when I got tired, I just sit in the nurse station. Several months passed, I have an office, and then I asked for genetics clinic. I asked for space for lab. I asked for equipment, for budget to do research, accept PhD, MSc students, and then we start from there and then grow bigger and bigger. At that time, before I got back here, I want to just see patients and then send sample out and then receive a clinical report. This is the molecular diagnosis. But there's no lab for me to send samples of my patients to. So I have to start the diagnostic lab too. So we have medical service, diagnostic lab, research lab, and training both scientific side and clinical side in the same team, because there's no one else that we can turn our, we can ask for help. That's the starting point. So we combine all the three pillars, service, research, and teaching. Then we have more and more people, starting from just me, and now we have more than 30 people in our group. And we can do, we have clinic every hour of the working days. We have specialized clinic. We have diagnostic lab again and research lab. We have teaching and clinical, both clinical and scientific sides. We identify many new human disease genes. We publish in leading journals, contribute to the world, and have a network, work with people in Southeast Asia. We just have publication about ASEAN genomics. And at the global level, I'm privileged to serve as a member in the Technical Advisory Committee on Genomics for WHO, World Health Organization. So we are very proud that we can help our patients and have something to share with the world.
Many people assume that sequencing is the difficult part. But as we were talking earlier, is technology really the bottleneck now? Or is it something else?
Right, it's the team. It's not just the technology, because the molecular diagnosis is just a step apart to help our patients. So the ultimate goal is to help our patients. Technology is very important, but it's just one step. We need to build the whole ecosystem. It needs the team, the whole team. So the clinical geneticist needs to really have the detailed clinical manifestations. The one who do the NGS, the wet lab, needs to be very careful and follow the protocol. Bioinformaticians, the variant scientists, really important. If they don't pick up the real one or don't really go through all the literature, maybe they miss the real causative variants. So it's a whole village.
I want to pivot to Thailand as a model. From the outside, Thailand is one of the most fascinating precision medicine stories anywhere in the world. What do you think Thailand's done particularly well in this space?
Okay. I think one of the strong points of Thailand is medicine. Because of the mindset of medical schools. When we were medical students, we see and were taught by our teachers. You can see this motto everywhere. Even when you go outside, you can see, but it's in Thai. It's everywhere that we are doctors because of what? We serve people, but then if we do it well, we have integrity. Other things such as fame or money will follow. We don't consider that as our goal. Do your job as best as you can. Thailand has a similar public health outcome as the world's largest economy, with a more than 40 times fewer budget. So it's very efficient. We can do this because of three things. One, in 1990s, every district, which has about 800 districts in Thailand, has a hospital. Then the second thing is every graduate from medical schools has to spend at least 3 years in these underserved areas. So we go out, we help our patients, and the salary is extremely low, but we are more than happy to do that. That's second. We have manpower to fill up the hospitals. And then the third, in early maybe 2002, we have universal healthcare coverage. So Thai individuals, no matter how rich or poor they are, they have been covered. No one should be bankrupt because of their illness. So now they can have, let's say, kidney transplant, renal dialysis, targeted therapy for cancer, even proton therapy without charge. So that's the strength of the public health of Thailand. Now come to precision medicine. Thailand is not a country that good at technological innovation, but I believe we are good at identifying and applying technologies to do our job. Now we are using long-read whole genome as first tier for rare disease, unless exome shows a good enough diagnostic yield. And we even go beyond that. We think why we have to wait for these patients to develop symptoms, because the genome has been there before they were born. So now we move to newborn screening. So we start with newborn using umbilical vein, blood from umbilical vein. So that start with at second 0. And we sequence once, but repeated the analysis, repeating the analysis to benefit their whole life. The first benefit is using it as newborn screening for genetic disease. And then when they grow up, for actionable genes, for pharmacogenomics, from carrier testing, and so on. So that's the story of.
You know, the first time I saw you present that slide, you know, comparing the US and every other country to Thailand, it was astounding.
What I just told is in a pilot stage. Thailand is good at identifying and adopting technology, but before any technology to be used under universal healthcare coverage, it needs to go through a very rigorous studies for health technology assessment. They need real evidence, so we need to study in our own country as a research, provide numbers, statistics for a team in health technology assessment to go through all their decision node numbers, alternative, this and that, whether it's economic, well, they do economic evaluation, they do feasibility, implementation feasibility, they do this and that, every aspect. If it's past the criteria, then it go to another committee to include it in the universal healthcare coverage. So now the long read, the LifeSeek project is in its infancy period, in research period. We are trying to generate numbers, information for them to do the HTA. If it's past the criteria, then it's go through, or even it's not cost effective at today. We are going to have number when the technology goes down to this number, it's going to be cost effective.
You know, that comes back to the earlier part of the conversation, the value of evidence generation, but the value of the village. We need the evidence now to be able to move into the space of precision medicine.
So we call our project LifeSeek, L-I-F-E. Life is a vision. Seek is a tool that we are going to use whole genome long read as a tool, started at second zero of their life because we use blood from umbilical vein to benefit their whole life. We spent about a year to communicate with the ethical committee. They have many questions. How many genes? What does it mean? Actionable. It's not the same as treatable. Actionable to whom? And if a new genes come up, what are you going to do? What are you going to do with the blood, the remaining blood, the data? How long you're going to keep it? This and that. 1 year before we get approved. And the first phase is not trying to get the number how much benefits this project is, but instead we want to have a big picture of the ecosystem, the ethical, legal, social issues. How does the OB doctors see this? Some OB doctors really against it. They feel that if we identify a genetic disease, then maybe the parents are going to ask the OB doctor, why couldn't you identify it when the child was still in the womb? That's probably a social issue. Legal, Thailand doesn't have a law similar to GINA, the Genomic Information Non-Discrimination Act. We don't have that yet, but it's starting point. So I raised this issue, and now there's a project studying that whether Thailand should have something similar to GINA, and what's the detail, and the project should end in a year. So we should have something similar, but of course not the same as GINA in Thailand soon. That's the legal issue. So lay out all the questions if we want to upscale this LifeSeek project. And LifeSeek is the lifelong benefits, but the first benefit is as newborn screening. We call this sub-project ANGELS, A-N-G-E-L-S. It's like advanced newborn genomics screening using long read sequencing, something like that, ANGELS. So we have to have the whole picture. So we have a pre-test counseling team to counsel the couples when they come to antenatal care clinic. When the first case, I did it myself. When the woman is 2 months pregnant, for at least 30 minutes for each couple. And then if they were just 2 months pregnant, we have to wait 7 months before they deliver the child. And then we have to communicate with the labor room or the operating room that after the child, the umbilical cord has been severed, and then after the child is safe, while waiting for the placenta to deliver, then we draw blood from umbilical vein. So it's going to be thrown away anyway, this placenta and the umbilical cord. So we use this for long read sequencing. Analyze and then return the results. But right now, the time is still quite long. We tell the parents, we give the numbers, the telephone number. If their child gets sick enough to get admitted, tell the doctors to contact us immediately. Then we analyze it first and then tell the result. Otherwise, it's going to take us about 8 weeks. We promise 8 weeks now, but we try to get better and better.
Can you remind me how you plan to scale this initiative? You know, where you're starting now after a year of debate, and what the long-term goal is in terms of the numbers?
The first phase, which is the first year, we want to do just 300. Basically, maybe around 1 case a day, to get all the ecosystem, to understand all the possible problems. Then the second phase, we are going to expand to 8 hospitals. The first phase is 1 hospital, which is our hospital. Second phase, from 1 to 8 hospitals, and move up from 300 to 1,000. And then the third phase is 10,000. And then we go from there. Whether it would go bigger, it depends on several issues. First is how much long read can get better benefits, more benefits compared to short read or gene panel. And the cost. So basically HTA. The cost is going down every year, while the benefits going up every year also, because we know more and more about variant of unknown significance. What does it mean? It's either benign or pathogenic. But right now it's variant of unknown significance. But next year, a lot of variant of unknown significance is going to be known, whether pathogenic, either pathogenic or benign. So the benefits increasing, the cost lower. So one day it's going to be cost effective.
Why do you think implementation has become such a big challenge?
Because it needs the whole village. Mm-hmm. If you don't have a village that are ready to adapt a new technology, even you give that technology to the village, which are not ready, it's not going to be there. But I can feel that right now it's like a tipping point. All of a sudden, a lot of institutions, hospitals in many countries realize and adapting this. If you compare last year and this year, it's like exponential.
So looking ahead, Thailand's experience has really demonstrated that implementation is possible. I think that the best example is what you've built here in rare disease. Which part of Thailand's journey do you believe could help accelerate progress across Southeast Asia?
I believe it has to start somewhere. And if you are a health professional, come together and then have a community such as patients supporting groups and talk to the policymakers. Tell them that this is what you're going to do. Ask for the resource. So now you have three parties, three stakeholders: the academia, the academic experts, the community. Convince the policymakers, and then you're going to boom.
Yeah, be able to take off.
Yeah, you cannot do it from just yourself. You need to engage other parties.
Yeah.
If in Thailand we have a story, a motto. If you want to move a mountain, you need three stakeholders.
Professor Vorasuk, this has been an incredible conversation. My last question is this. If a child born anywhere in Southeast Asia 5 years from today could benefit from everything we've discussed today, what do you think has to happen between now and then?
We need to spread our trust, work hard, join forces, and our dream will come true. We cannot, if you want to go fast, we can go alone. But if we want to go far, we want to sustain, we have to go together. That's the only way. We have to join forces and keep doing, give positive power to one another, and it's going to bounce back.
Thailand has truly shown what's possible.
Thank you. We have come quite far, but there's so a long way ahead of us. We need to keep going. We need to share. The more we share, I believe the more we're going to get. We keep going, sharing. Thank you so much.
Thank you. Thank you for joining us on Precision Health Decoded.
Thank you.
Some of the most important stories in precision medicine don't begin inside a laboratory. They begin with relationships, with conversations, with people who believe healthcare can be better. And over the past year, I've had the privilege of getting to know Professor Vorasuk, not only as one of Asia's leading physician scientists, but as a thoughtful colleague and a steadfast advocate for bringing precision medicine into everyday healthcare. Thailand has truly shown what's possible. The question now is how we make it possible everywhere.